there's a lot of bets that are made on AI to alleviate some of these burdens. The whole revenue cycle area is ripe for opportunity.
Welcome to Off the Chart, a business and medicine podcast featuring lively and informative conversations with healthcare experts, opinion leaders, and practicing physicians about the challenges facing doctors and medical practices. My name is Austin Luttrell. I'm the assistant editor over at Medical Economics, and I'd like to thank you for joining us today. This week, we're looking at one of the biggest headaches for physicians, prior authorizations. Designed as a cost control tool, the process has grown into a major source of red tape, eating up hours of staff time, delaying care, and frustrating both doctors and patients. Medical Economics Managing Editor Todd Shryock sat down with Brad Boyd, Principal of Management Consulting at BDO USA, to talk about whether AI and other technologies can finally make prior auths less painful. Boyd explains how new tools are already pulling data from EHRs, flagging potential denials, and helping practices skip unnecessary steps altogether. Thank you again to Brad for joining us, and now let's get right into the episode.
Joining us today is Brad Boyd, a principal of consulting firm BDO, to discuss prior authorizations and how AI might be able to help streamline the process. Brad, thanks for joining me.
My pleasure. Thanks for having me.
So, Brad, currently, from your perspective, what are the biggest pain points in the current prior authorization process for physicians and their staff?
Okay, so coming out of COVID, there's been several just headwinds that have challenged financial, provider organizations, and labor shortages has been one very impactful, and unfortunately, it's an issue that's here to stay. So when you look at things like prior authorizations and just most revenue cycle functions overall, they're really administrative functions. They're necessary because providers need to get paid for all the clinical work that they do. It's not adding value. It's not why they went to medical school, but it's an unnecessary part of the healthcare system and making sure providers are getting paid. There's also been several kind of over the last year and a half, there's just been some trends. I mentioned staffing costs, mentioned some just challenges with administrative work, but there's also been a significant increase in denials from payers across the board. One of the sources of those denials relate to prior authorizations. So the volume of denials has gone on. There's also been a shift as more Medicare lives have shifted to Medicare Advantage plans. Those Medicare Advantage plans have much more, have greater requirements regarding prior authorizations. And so the administrative burden as the number of covered lives under Medicare Advantage plans has increased, the administrative work of all the prior authorization requirements over larger population, and then denials that result after, whether it's all the prior auth work has been completed or not, the increase in denials has just created extra pain points for provider organizations. So labor costs have gone up. Now there's additional administrative costs, whether it's prior authorizations or denials, and at the same time, reimbursements being cut. So we have higher operating costs, more administrative work regarding claims to get paid, and higher, denial volumes has just led to pressures on provider organizations that these, provider organizations have always operated on razor-thin margins. When now they have higher operating costs, more administrative work regarding prior authorizations and appealing of denials. It's really left the industry in a uncomfortable position where it really is getting to the point where razor thin margins to begin with are not really sustainable. And unfortunately, the administrative work here is it's really not adding value. It's all really paperwork, unfortunately.
So where do you see AI having the most immediate and practical impact on this prior authorization process?
So I think The overall revenue cycle area, prior authorizations, denial management are ripe for automation, including artificial intelligence, because we want to take our most valuable resources, our clinical staff, and a lot of prior authorizations start with clinical staff, and nursing and care managers are very involved in that. So the extent that automation we can shift some of these administrative tasks to an automated solution, it frees up those resources to do more patient-facing work, whether it's patient care, more coordination of care. So it'll help, moving that to a digital or automated experience will really help reduce the overall, either reduce labor costs or the volume of resources that are needed, or take the resources that are already employed and shifting them to more of higher value added administrative work. So there's a lot of hope that the industry is placing on automation and AI, and I think prior authorizations is ripe. And this was actually automation in this area was being focused on well before the pandemic started. But now that I think as artificial intelligence has evolved, there's there's greater solutions out there to have a meaningful and sustainable impact on reducing the cost and administrative burden with prior authorizations.
Would the AI be more of a kind of simple rules-based system, or do you see the agentic AI getting, a place at the table where it's maybe having a little more leeway in how it's operating?
So a great question. And I use I reference automation and AI separately because they're related, but they are different. So rules-based logic, RPA, now there's agentic kind of RPA. That's really where your rules-based kind of approach goes. And there's been a lot. RPA has made a real impact in revenue cycle management. But I think the holy grail really comes around agentic AI and looking at behaviors, looking at proactively looking at patterns of where claims have been denied for, say, different areas of prior authorization, and knowing in advance what a claim might, this claim will most likely be denied based on past performance, and what are the steps necessary to appeal that, and doing some of this work kind of behind the scenes in an automated fashion. In some cases, AI from the true agentic AI can look at claims as physicians or nurses are doing documentation and doing the documentation and coding of the claim. And behind the scenes, they can really say, okay, based on our recent patterns, these are areas where that claim can be denied. And that could either provide alerts to the clinician, or better yet, it can start to organize some of the documentation. So when payers allow documentation to be submitted with initial claim, it can say, we're going to submit this information with the claim because we know based on history that this is a high likelihood that it's going to be denied for these reasons. So we're going to attach those parts of the clinical note with that claim up front where it's possible, just to mitigate the delay in that cash and all the work that's involved in working that denial. So I think agentic AI is very different from rules-based. It really is more of the when we talk about AI today, I think a lot of people might not know the term agentic, but that's really where we're looking for where the computer is working at a higher level of intelligence based on that past history, much more advanced than traditional rule-based logic.
Say, Keith, this is all well and good, but what if someone is looking for more clinical information?
Oh, then they want to check out our sister site, PatientCareOnline.com, the leading clinical resource for primary care physicians. Again, that's PatientCareOnline.com.
Do we have the data inputs that exist today in with payers and practices to make all this work? Is there going to have to be additional data input into the system, or do we already have what we need to work with?
Another good question. I think we have the data exists from practice management systems or revenue cycle systems, electronic health records. However, Based on our work, what we see with organizations is there's not a sound understanding of the prerequisites for an agentic AI solution to work. The data might be there, but it might not be stored in a warehouse or a organized fashion with sound data governance that then agentic AI can work off of in a more automated and streamlined fashion. So the data might exist, but it might not be stored in the right process with standard data sets. There's requires some like data management and governance around that data. That's a big step that is often not understood for a true agentic AI solution to work. So the data is in your systems, but it typically needs to be stored or staged in, say, a warehouse or repository with sound control and governance around it, so that then the AI solutions can really work in a streamlined fashion.
Will these systems be on the provider side, or could it possibly be on the payer side where you're putting in data and it's already flagging it for you? I guess, which side of the fence will these systems be on?
Well, most of our work is on the provider side. So I think there's a little bit of a battle going on in AI between the providers and payers. The data exists, and there's also a lot of tools and automation regarding prior authorizations that technically exist. But unfortunately, the incentives aren't really aligned between providers and payers. So there are solutions out there that can automate many of the prior authorization tasks, requesting a procedure or an imaging test. All the information's in the chart based on the payer rules that prior authorization request could go to the payer. That payer could get access to the information from electronic health record if both parties had the necessary security set up and access to set up. So that could automate that prior authorization request from days to seconds. However, the reality is the providers don't necessarily trust the payers to look at that chart in a independent fashion. What information might they look at that might lead them to deny that claim? Payers aren't really incentivized, or provide payers aren't really incentivized to automate that prior authorization, because the longer it takes for that authorization to be approved, the cash is in their bank earning interests. So it really is a lack of alignments in incentives. So payers will use AI tools to scrutinize claims before they're paid, or to scrutinize prior authorization requests. And providers are just really trying to figure out what's the most efficient way to convert their clinical activity to cash. It's a real unfortunate lack of incentives, because there are tools that exist today that if both parties wanted to work very collaboratively, but unfortunately that it's the incentive piece. They're what works best for the providers means payers are going to pay claims faster, and that's where that breakdown in incentives lies.
It makes me wonder, is there any danger of a world where AI is sending in the claim, the payer AI is rejecting it, the provider AI is appealing it, where it's like two AI systems arguing with one another?
Unfortunately, I think that's already happening, whether it's, AI or some type of rules-based logic. There's been a significant increase in denials over the last year and a half. Some industry reports about 20% increase in denials. That's not because providers are not doing their work, or that they're trying to provide services that might not be medically necessary. There's always going to be, you know, there needs to be checks and governance around compliance. But I don't think it's realistic that there's been a significant increase in poor behavior on the provider side, where they're providing services that are not medically necessary. Um, so I already think they are battling, and it's a lot of gamesmanship. And for these businesses that are still struggling financially coming out of COVID, higher operating costs, lower reimbursement. Now you add this administrative burden on prior authorizations. Um, it's really something that it's it's really impactful of provider organizations. And I think the when you're operating on such thin margins to begin with, when you delay cash, or the cost of collecting that claim increases dramatically, it's a environment that's not sustainable. And so hopefully AI in the provider side can help address some of it. Ultimately, though, I think there does need just to be some better alignment in the incentives between purveyor and providers, because um, we're all consumers of that medical services, even though we're professional, administrators on that work with providers and that work with payers. At the end of the day, we want our providers to spend their time taking care of us and our family members, and uh, it's something that's there's a lack of balance that's occurred over the last couple of year and a half. And I know from the provider side, AI is for many areas in the whole continuum of patient care. There's a lot of bets that are made on AI to alleviate some of these burdens. Um, the whole revenue cycle area is ripe for opportunity.
Will these AI tools for prior auth be integrated into the existing EHR workflow, or is it going to have to be some additional step for a physician to avoid a prior auth?
I think it absolutely needs to be embedded into the clinical workflow, the administrative workflow, whether it's on the patient access side, and when scheduling when schedules are booked, and the an extension of the eligibility verification process to understand prior auth. It really does need to be embedded. We work with a lot with organizations that are taking different approaches to figuring out what are the right tools. Whether it's going to be your EHR or your revenue cycle system vendors, they're working on some functionality that includes agentic AI. There's a lot of third-party vendors that might address a couple of different use cases, and they have AI solutions that has to be integrated into the overall kind of end-to-end clinical workflow, as well as organizations are looking at maybe using some third-party tools immediately to do a lot of learning regarding AI, and get governance programs and proof of the concept to get some short-term wins and demonstrate that value. But longer term, I think they're looking for developing more proprietary AI solutions. We conduct an annual survey of healthcare CFOs, and this year, about over 90% of the CFOs reported that their longer term strategy would be some type of proprietary AI platforms that they would develop based on their own data sets and their own, electronic health records and revenue cycle systems. They view that will be, they know their business, their patients, their payers, their providers the best. But they view a lot of the pre-work that's necessary to do that. They don't want the pursuit of perfection to get in the way of meaningful progress. So they're starting to invest it with a balance of some third-party solutions, or using some of the tools that their EHR or revenue cycle vendors are providing while they are learning about this. And that learning is going to go towards to development of some internal proprietary programs. I think the type of organization you are really depends on your approach regarding, by build versus buy. If you're a big academic medical center, you have all this research, you have so much data, and a little bit more of resources, you're probably able to develop and maintain, a proprietary AI platform a little bit better than, say, a smaller group practice that doesn't have all those resources. You're more dependent on some of your existing vendors or a third party solution. So those are, very common conversations that we get engaged in daily across the country, as organizations are they're planning around AI, and how it can, what are the best use cases where it can start to have an impact in revenue cycles logical. But they want to do so very strategically to make sure that they're going to learn and demonstrate value, and build and go and grow, is how we call it, to learn and then apply those learnings to expand your AI program.
What about the small independent practice or the rural practice? Are they going to get left behind, or will they be able to take advantage of these tools?
Well, they certainly don't have the resources from an investment that, say, a larger health system or academic medical center would have. I think they'll be a little bit more dependent on their existing EHR rev cycle vendors to develop and extend those tools to them. So I think that's number one is just the reality is that they'll be a little bit more dependent on their existing vendors as opposed to, say, homegrown development. We also see a lot of clinical alignment work happening where, say, a rural health centers or community practices have becoming not necessarily employed or owned by larger systems, but there's been a lot of clinical alignment activity and leveraging, say, the Stark laws where those bigger systems or medical centers can extend their EHR systems to those community providers. And if they're involved in those types of relationships, those practices or say a rural health facility, then they could, if they're going to be going on their clinical partners' electronic health record system, they often benefit by using the ecosystem of IT tools, which could include AI. But if you really are independent on your own, you're somewhat limited because you don't have the capital to make investments like a world-class academic medical center. It could be something that it would be unfortunate if they're left out because they still have the same issues of getting clean bills out the door and getting paid timely, and that could really grow some of the gap in financial performance for some of those rural or independent community providers out there.
Hey there, folks. My name's Keith Reynolds. I'm the editor of Physicians Practice. And for this P2 Management Minute, let's wrap about 3 red flag behaviors that mean it's time to let an employee go. Number 1, repeated compliance violations. Snooping in EHR, sharing passwords, any privacy breach invites 6-figure HIPAA fines and lost hospital contracts. If someone ignores written policies after counseling, your duty to protect patient data outweighs a second chance. Number 2, toxic disruptive behavior. Gossip, chronic negativity, outright defiance, drain productivity, and chase good staff away. Patients feel the tension too. Document every incident and coaching attempt. If the attitude persists, swift termination protects your culture. Number 3, dishonesty or suspected theft. Missing deposits or altered ledgers signal embezzlement. Practices have lost hundreds of thousands to trusted insiders. Theft warrants immediate dismissal, and usually a call to your attorney, insurer, and possibly law enforcement. Protect patients, team morale, and your bottom line by acting on these warning signs. For more bite-sized practice tips, make sure you visit physicianspractice.com. Thanks for watching, and I'll see you tomorrow on the P2 Management Minute.
Do you feel that we're at a tipping point with prior auths in general? I mean, there was the big AHIP announcement this week about for the second time that they're going to finally address prior auth. It's getting a lot more attention, from regulators. There's been a lot of public uproar about it. Do you feel like we're at a tipping point and technology might help finally solve this problem that no one seems to like?
I hope so. I hope so. I think the financial stress of the healthcare provider world, we feel it's a little bit more sensitive now than it was coming out of COVID when there was some government funding that was coming out, or in other periods of time, 2008, 2009, with interest rates going high. I think the higher operating costs of these organizations at this point, you add on the complexity or the additional costs of getting paid, it's not sustainable. Now there are technology tools out there. There's some of these tools around prior authorization. Some of them existed before the pandemic. They just haven't been adopted. And some of the reasons for that lack of broader adoption deals with either issues of trust between providers and payers, which are reasonable, or lack of incentives. I do think we're at a tipping point where some programs, whether it's gold card programs around prior authorizations for those types of programs, Some of the regulations that have been announced or proposed regulations this week around, possibly eliminating some prior authorization requirements. Um, there has to be a better mousetrap. And it's not a matter of putting a third, a person on the moon. It's getting it's they're unfortunately, I think regulators and Washington, D.C. can play a role in pushing this through, which is hard for me to say, because I don't think that people that don't understand healthcare should be making policy decisions about healthcare. But this is an area where the volume of denials is out of control, and the impact it's having on provider organizations who treat all of us and our family members is significant.
Are there ethics issues involved with getting AI into the prior auth process? I mean, we're talking about medical necessity, very personal decisions, and life-threatening decisions in many cases. What are your thoughts on the ethics of all this?
I think there are a lot of ethical issues and real concerns with AI. I think for one like within clinical care and clinical decision making, I'll push that aside for a moment. But the responsible use of AI, I think everyone that we work with, I think recognize the importance of using AI responsibly. Um, Governance plays a significant role, and we do see organizations that are aware of not just the governance requirements, but the ethical use of AI. Providers you go to medical school to take care of patients, so they want to do right. There are lots of risks when it does come to where data is stored and how that data can be protected, because AI tools typically, while they can pull information and interact with an electronic health record, they're often pulling information, say, from a data warehouse or a third-party tool. Cybersecurity is another major challenge in healthcare that is widely understood as an issue. So how that data can be stored, how it can be accessed, read, write, vary in a manner which doesn't expose protected health information to bad actors, to making sure that it's used appropriately. You're not sharing information with, say, a payer that might be used for other purposes. Um, that all plays a very important role. I think it's recognized as an issue, and it's more compared to, say, 2 years ago. I think there's such an awareness around protection of information and also responsible use of AI that it's not as much of a barrier to moving forward with these programs today as it could have been a year and a half ago, 2 years ago.
If a healthcare organization is looking to streamline their prior auth process, where would you advise they start?
Number one is it starts with having a strategy. For I think, there's areas of revenue cycle that are already being approached, whether it's automation, advanced like RPA or true AI. It starts with having a strategy. Organizations shouldn't look at a tool or a product just to address prior authorizations. What are your longer term objectives? Build a program and a strategy around a collection of use cases that you can understand. How do we prioritize where we want to make those investments? Start off, demonstrate success, demonstrate value, learn, have the proper governance in place, monitor performance, set our targets and how we're measuring our benchmarks, and then use that to expand the program to address additional use cases. If some organization jumped to just address prior authorization, it's a logical starting point. There's a lot of pain points there, but don't start just with the end game of just addressing prior authorizations. Because if you're going to pick a vendor to be your partner, you don't just want to have one vendor that does one use case and another vendor that does another use case. Because at the end of the day, you'd probably have a dozen different vendors that all have to interface with your data warehouses, your electronic health records. That becomes very expensive, and there's a lot of risk around data breach. So have the longer term strategy. prioritize your use cases, then pick your vendors. Are you going to be using your EHR or your revenue cycle system vendors? Might be the appropriate third-party vendor that can support some of your prioritized use cases? Then, broader speaking, what might you want to focus on proprietary solutions? If this is done regarding, laid out for a longer term strategy, that is where organizations are seeing more value or more return from these investments than just cherry picking one use case or two use cases. Funding becomes a big piece of that because you don't want to just fund one product or one solution. You do want to have executive level commitment to these programs so that they can be, expand, not just be sustainable, but expand them over time. And that requires just more thought. And there have been some vendors in the AI space that have focused on revenue cycle areas that don't exist today. A lot of money was raised, a lot of money was spent by providers. I'll call them early adopters, but they weren't really solutions. It was real custom development. And I think there was so much hope that these tools could help, fix real revenue cycle problems that providers took some early bets. They didn't do so with a longer term strategy in mind. And that's where I think the organizations, and there was an industry publication that said organizations that approached AI strategy, agentic AI programs that had a real strategy involved, strategy laid out, had a 4.5 times return on investment from those programs than organizations that were just picking a product to solve a particular use case. And so I think that's where organizations certainly have opportunities to address prior authorizations and some of the and denial management immediately, but lay out a strategy and then figure out what are the right use cases to prioritize based on the pain point, the investment required, the ease of implementation, because you want your first investments in AI to have an outcome and to produce value, because that's how you're going to receive more funding to expand these programs. And then when you get into the clinical care, you've got governance, there's more safety around it. And that's where I think the hope is for all of us, where you can then take some of the more work effort off of our providers to ease some of their burnout challenges. Because there's a lot of hope that AI can help there as well. But if you do so in a very thoughtful process, hopefully there's just going to be more longer term success.
Is there anything else that you would like to mention that we haven't talked about?
No, I think that the strategy was something that I really wanted to emphasize because the laying it out in a very thoughtful process, as opposed to just focusing on one use case, denial management, prior authorizations. The defined strategy helps you really understand what are the real requisites around data, around governance. What do we need to do regarding our core systems? Take fully advantage of the technology, electronic health records and billing systems we have in place. We're, as consumers of healthcare services, not just professionals who help organizations in the space, we're all counting on AI to improve our overall healthcare delivery system, and we want these early initiatives to succeed. And to really be successful, I think requires the strategy, a longer term strategy. There's many use cases that are ripe for solutions. Prior authorizations are being one, but do it in a thoughtful manner so that these programs can not just be a year-long project. They want to be sustainable over the long term.
Very good. Brad, thanks for joining me.
Great. Thanks for having me.
Once again, you just heard a conversation between medical economics managing editor Todd Shryock and Brad Boyd, a principal of management consulting with BDO USA. My name is Austin Luttrell, and on behalf of the whole medical economics and physicians practice teams, I'd like to thank you for listening to the show and ask that you please subscribe to Off the Chart wherever you get your podcasts so you don't miss the next episode. Also, if you like the best stories that medical economics and physicians practice publish delivered straight to your email 6 days of the week, subscribe to our newsletters at medicaleconomics.com and physicianspractice.com. Off the Chart, a business and medicine podcast, is executive produced by Chris Mazzolini and Keith Reynolds and produced by Austin Luttrell. Medical economics, physician's practice, and patient care online are all members of the MJH Life Sciences family. Thank you.